today I would like to discuss MSICS Pro, which is giving cosmetically good results. This is the technique that the cornea is ensured to be clear, and is white, and there is minimal ECG reaction over it. The eyeball is stabilized with the process holding, female station, delicately, with your non-hand, hand, causing without causing loose touching. Continuous play is continuous play is avoided by doing the further ceremony in the recent play. Here I have inserted various amount of viscoelastics and then develop a system inside port. This is the particular styling characteristic is made. The characteristic is aided by the good representation, which can be quite representation in the eyeball to the system. The particular technique which done present play and major results are avoided, and this helps in keeping the sclera little clear. And then straight incision is made either with superior frontal or superior nasal quadrant, and then clear corneal tunnel is made. This clear corneal tunnel ensures that the nucleus quietly comes out to the vision chamber. So now the AC is entered to the keratome. Keratome is entered by going inside, and once this is done, the next step would be to doing this. The particle theory hybridization. Particle theory hybridization ensures that the nucleus is free from the capsular bag and it is collapsed to the anterior chamber. Once this is done, we can remove the nucleus by the sample system, wherein focus and direct also to the base. The entire procedure is done by installing two blocks of paraffin, four paraffin. Here the nucleus is washed out in the specific procedure. Care is taken to ensure that the maintain deep water. So if the particle wash is then finally done by using the side fork incision, the audio ends cortex has been aspirated out, the things become quite easy after that. So next step would be to place the intraocular lens. So the intraocular lens IOL has to be placed inside the bag. Now that we have a good view of the capsular margin, we can insert the lens under hydroimplantation by keeping the synco inside at the edge of the sclerocorneal tunnel, and then push the lens. First the leading aptic goes inside the bag, and then later the trailing aptic is dialed inside. The entire now the IOL is inside the bag, and then the side folds are hydrated. And this is the end of the surgery, and the conjunctiva is closed by just approximating with the forceps. So this is a cosmetically appealing surgery because it do not need to be patched. This is another case of soft cataract wherein the side port incision is made. There is a good glow, so that is why I am not staining the capsule. Viscoelastic is injected, and then with just pushing the eyeball, I get a good retroillumination. With based on that, I just do a CCC. CCC is done by just lifting the anterior capsule, having a nick, and then going circularly. So all the steps are done topically, and the patient is not experiencing any pain. The capsular edge is round, central, and it is equidistant from the margins. And now the conjunctiva. Conjunctiva is just peritomy is done by using a crescent blade instead of a scissors. This ensures that the dissection is minimal and the bleeding is less. So the incision is made with the crescent blade itself, and then the sclerocorneal tunnel is made by bringing moments, bevel up and bevel down. The sclerocorneal tunnel ensures that the wound is self-sealing in nature. So this technique involves delicate holding of the globe. The wound is not supposed to be tampered with, and care is taken that so that the wound is not to be touched with the forceps. AC is entered with the keratome, and it is extended at both sides. and now you can see the excess margin which is round and central. Now just inserting saline by in the form of iododissection, which is a cortical cleaving. You can see the nice golden ring, and then it is hydro is done at both the sides, and the one pole is lifted into the anterior chamber. Once the pole is collapsed into the anterior chamber, the rest of the things, the cavecties can go inside the posterior lip, and then the nucleus is delivered out of the syncytium. So next is your epinucleus and cortex, which can just be aspirated or just press the posterior lip, and the cortex just comes out. So this is one easy technique where you can give a cosmetically good looking eye, and atraumatic, and it is painless. So finally the cortex is being removed, but starting with the side port incision. The cortex is removed from the edges of the capsular to the edges of the capsular opening, and then finally the subincisional cortex. So this technique ensures that the patient doesn't have any pain, because we are not touching the iris and we're not letting the anterior chamber collapse at any point of time. So in that way, the side port incision is of a great help. And finally, when you're implanting a lens, you can either do it with viscoelastic, or you can just use a Simcoe cannula at the edge of the tunnel and then push the lens inside the bag. First the leading haptic goes inside, and then the trailing haptic. So that is about MSICS Pro, which gives results on par with phaco, and the post-op recovery is good, and the patient doesn't find a difference between two of the techniques. So I would like everyone to start doing MSICS in a topical way and give good results to the patient. Thank you for your attention.
Thanks a lot, Dr. Gopal. Very nice videos. Any questions from the audience?
Sir, what are your views on this topical SICS? Would you, in your private practice, would you prefer this method?
No, so if these are the cases that I was doing, I would do a topical clear corneal temporal phaco. All right. So even if it is a, let's say, outreach program patient, I'll still use hydrophilic acrylic lens, but to a phaco. But then this is a question of, I have actually been doing this technique for more than 30 years. What Gopal has shown, it's a deja vu for me. So this is a good technique, and it can be done under topical anesthesia. It is somehow a myth that SICS has to be done under peribulbar or subtenous. No, it can be easily done under topical anesthesia. Maybe in certain patients where intraocular manipulations, you can use intracameral xylocard. That's it. But otherwise, it can be done.
But every time you're holding the conjunctiva, the patient doesn't feel pain?
No, he doesn't feel pain.
He has used a proparacan eye drops.
Proparacan eye drops started the surgery. Then hold this thing and ask the patient to keep looking at the light. He should not move his eyes. He doesn't experience anything. No need of giving any subconjunctival.
But all's well until everything is going well. Once any complication happens,
then you can just supplement it with the subtenance injection. Subtenance you can give and then continue with the case. Especially so in hard of hearing patients, hard cataract, pseudo exfoliation. Better to avoid topical in such cases. You can start as a topical and then you can supplement with the subtenance.
After this procedure, you are immediately.
I'm not patching it. We start with the post-op medications, and the patient is followed up the next post-op.
No, same day sent home after 2 hours or immediately?
Immediately sent off. No need of patching. Only thing is the hemostasis has to be achieved. You need to close the conjunctiva, approximate it with forceps, keep it for a few seconds so that it gets attached. Patient does well.